Thank you. Thanks, Vivek, for the introduction. And thanks, everybody, for having me today. I'm very excited. I cannot monitor the chat, so Lindsay will monitor. And please ask questions during my talk. I would actually prefer to have more of a discussion with you as opposed to a lecture. So at any point during my talk, if you feel like you need some more clarifications or you have a more elaborate question, please stop me, because actually the way I planned this is a 35-minute talk to make sure that you have enough time to ask questions and for me to answer. So please take advantage of it. And I do like emojis, so you can put emojis in the chat. I can't see them, but Lindsay can interpret the emojis for me. All right, so I am going to tell you today about 3 different types of adaptive interventions, and I'm going to tell you about 3 experimental approaches that you can use to optimize them. And this talk is intended to be a brief and accessible introduction, so you're not going to see any equations here or anything statistically intimidating or challenging. It's just to show you the intuition for how we can think about these experimental designs and how to think about the data analytic approaches that you'll need to use to analyze data from these experimental designs to answer different kinds of questions. So this is, and I can't move to my next slide. Okay. Okay, so before I start, I wanted to thank my amazing collaborators and also NIH, especially NIDA and NCI, for funding this work. I also wanted to mention that all the examples that I'm going to show you today, they're based on work by my amazing colleague, Maureen Walton from the Department of Psychiatry at the University of Michigan. But I did modify all the examples for illustrative purposes, so this is not how she implemented them in practice. Okay, so this is how I'm going to structure my talk. Okay, this is just an overview. Now, I'm going to mention a few definitions, but I promise that I'm going to mention them again later on, okay? So I'm going to start by telling you about adaptive interventions. I'm going to define adaptive interventions. And specifically, I'm going to define the concept of adaptation as the use of dynamic information about the person to make intervention decisions, to decide whether and how to intervene. And then I'm going to show you how adaptive interventions can help you guide the adaptation of human-delivered components on a relatively slow timescale. So when I say slow timescale, I typically mean every few weeks or every few months, but I know that slow and fast is relative, so we can talk about this later if you're interested, and I can give you a few other examples for slow and fast in different fields. Okay, but for now, adaptive interventions, they guide the adaptation of human-delivered components on a slow timescale, where slow means every few weeks or every few months. And then I'm going to talk about the sequential multiple assignment randomized trial, the SMART, to show you how this experimental design can help you answer scientific questions about how to best construct standard adaptive interventions. All right, then I'm going to switch to just-in-time adaptive interventions, or what we call JEDIs. And I'm going to show you how JEDIs can be used to guide the adaptation of digital components on a relatively fast timescale. And when I say fast, I mean every few days, hours, minutes, sometimes seconds. And then I'll talk about the micro-randomized trial. And I'll show you how the MRT can help you answer scientific questions about how to best construct JEDIs. And finally, I'll focus on multimodality adaptive interventions, or what we call MADIs, because we love acronyms. And I'm going to show you how MADIs can help you guide the integration between human-delivered and digital components that are adapted on multiple timescales, both slow and fast. And then I'll talk about the hybrid experimental design, and I'll show you how this trial design can help you answer questions about how to best construct multimodality adaptive interventions MADIs. Now, when I say hybrid designs, I don't mean hybrid effectiveness implementation trials. I mean hybrid optimization trials. And I'm going to explain what I mean in a second, but that doesn't mean that hybrid designs or MRTs or SMARTs cannot be hybrid effectiveness implementation. And if we have time, we can talk about this as well. All right, but before we start, two important distinctions that we need to make. The first distinction is between an intervention delivery framework and an experimental design, and many people conflate the two. This is very interesting. And I think people conflate the two because sometimes we use the term intervention design to refer to intervention delivery frameworks, and I think this is what gets people confused with experimental design because it sounds too similar. But these are two different things, okay? So what is the difference between the two? An intervention delivery framework is the answer to the question, how should practitioners, those who deliver the intervention in practice, think, the coaches, the therapists, the digital technology, what guidelines, what principles they should follow to implement the intervention in practice? That's an intervention delivery framework or an intervention design. Okay, so what is an experimental design? An experimental design is the answer to the question, how should we investigators, how should we systematically manipulate independent variables so we can answer scientific questions that are of interest to us? In experimental designs, we have randomizations, random assignment of participants to experimental conditions. The reason we have randomizations is because we want to answer causal questions. We want to make causal inference with limited structural assumptions. That's why we randomize. We want to answer scientific questions. In intervention delivery frameworks, we don't have randomizations because the goal is not to answer scientific questions. The goal of an intervention delivery framework is to guide the delivery of interventions in practice. And I want you to think about you trying to guide someone in delivering an intervention in practice. What do? You give them a protocol, right? You don't randomize. So no randomizations in adaptive interventions, JEDIs, and MADIs, but we do have randomizations in SMARTs, MRTs, and hybrid designs because these trial designs are supposed to help us answer scientific questions about how to best construct different kinds of adaptive interventions. All right, the second distinction that is also very important is between optimization and evaluation. All the trials that I'm going to talk about today, these are, sorry, allergies. These are, I love the trees here, but, has consequences. All the trials I'm going to talk about today, these are optimization trials. These are not evaluation trials. The goal of these designs is not to evaluate, not to confirm the effectiveness of an intervention relative to a suitable control. The goal is to optimize an intervention package. So what is optimization? This is the definition that Linda Collins has for optimization in her book. It's a 2018 fantastic book about optimizing biobehavioral and behavioral interventions. But basically, optimization is a process where systematically we are trying to select the best components for inclusion in our intervention package and to integrate them in the most effective and resource efficient manner. And in her book, whenever Linda talks about optimization, she uses the term looking under the hood. And I really like this because it makes me think about building a car, okay? So when you think about building a car, you think about selecting the right parts and putting them together in such a way that the car would not just be fast. You want the car to be cheap. You want it to be fuel efficient. You want it to be environment friendly, right? And you want to do this to put together the best car ever before you take the car for a ride and compare it to other cars, right? So that's what we do in optimization. We put together the best intervention package that is most effective and resource efficient, and then we compare it to other cars. Then we compare it to a suitable control with a standard randomized control. All right, and now I think we're ready to talk about adaptive interventions. Okay, so what is an adaptive intervention? I said this before, but I promised that I'm going to repeat definition. So an adaptive intervention is an intervention delivery framework. It's a guide for how practitioners should deliver interventions in practice. But adaptive interventions are special because they guide how practitioners should adapt interventions in practice. And by adapt, I mean use dynamic information about the person to decide whether and how to intervene. So why do we want practitioners to adapt interventions in practice? It's because we want them to be able to address not only the unique, but also the changing needs of people as they progress over time. And standard adaptive interventions, they're typically motivated by the need to address conditions that change relatively slowly every few weeks or every few months. That's why the adaptation happens on a relatively slow timescale. And these interventions, they typically guide the adaptation of human-delivered components. And by the way, they can also guide the adaptation of other components that can be adapted on a slow time scale. And if we have time, I'll show you an example. But for now, I want you to focus on this example. This is an example of an adaptive intervention for youth who visit the emergency department. The goal is to reduce their substance use. This adaptive intervention starts with a relatively minimal form of support, single session in the emergency department, plus a digital intervention that delivers a message, a tailored message on a daily basis. At week 4, they assess the participants' response status. If the participants self-report to use drugs at week 4, they're classified as non-responders, and they transition to the second phase where they receive remote health coaching. This is human-delivered coaching. Otherwise, they're classified as responders, and they continue with the same initial intervention. Okay, so there are 2 things that I want you to notice about this example. The first thing is that this intervention is adaptive. There's an adaptation process here. There's an adaptation process because we're using dynamic information about the person's response status to decide whether or not we should add coaching. The second thing to notice is that the adaptation process here happens on a relatively slow time scale. It happens 4 weeks after program initiation. Why? Because we're trying to address conditions that change relatively slowly. We're trying to address early signs of non-response to this minimal support, which is expected to unfold over 4 weeks. That's why we adapt the intervention 4 weeks after program initiation. That's why we adapt the intervention on a slow time scale. All right. The issue is that in many cases, we, investigators, we have scientific questions about how to best construct adaptive interventions. And I want to share 2 scientific questions that I have about how to construct this specific adaptive intervention. The first question that I have is about how to best initiate this adaptive intervention. You see, the assumption here is that I should start with relatively minimal support. But I wonder if it would be more beneficial in terms of reducing the number of substance use days by week 16 to actually start with a little bit of coaching, bring coaching right off the bat, in addition to this minimal support. So that's my first question. The second question that I have is how to best address the needs of non-responders at week 4. You see the assumption here that I should step up for non-responders at week 4, but maybe it would be better again in terms of reducing the number of substance use days by week 16 to simply continue with the initial intervention. Just give people more time with the initial intervention. Okay. Notice that I have repeated the outcome that I'm focusing on multiple times. I sound like a broken record, but it's really important because this is a really critical scientific practice that we all need to adopt. Whenever we specify scientific questions, we have to specify the outcome. Second reason why I mentioned this multiple times is because I want you to notice that the outcome that I'm focusing on here is actually a distal outcome. It's a long-term outcome. And later on, when I talk about Jedis, I'm going to focus on a proximal outcome, and I want you to notice the difference between the 2. And if you remember, please ask me why. Why is it that here I'm focusing on a distal outcome, and when I'm focusing on a Jedi, I'm focusing on a proximal outcome? I'm trying to engage you, okay? All right. So how do we answer these 2 questions? This is why we have the SMART, the Sequential Multiple Assignment Randomized Trial, developed by Susan Murphy and colleagues. The SMART is just a randomized trial. It involves random assignment of participants to experimental conditions. But it's a special case of a randomized trial because it includes sequential randomizations. So what does it mean, sequential randomizations? It means that the same person can get randomized more than once in the course of the trial. In the SMART, every stage of randomization that you have corresponds to a decision point in the adaptive intervention that you want to develop. A decision point is a point in time in which practitioners would need to make a decisions about whether and how to intervene. But it's also a point in time for you, the investigator, where you have scientific questions about the selection and adaptation of intervention components because you want to guide the practitioners, but you don't know how. That's why you randomize. Okay, so for example, if I don't know how to initiate my adaptive intervention with or without coaching, then instead of starting the intervention with minimal support, I can randomize to the intervention with or without coaching. And then if I don't know what to do for non-responders, step up or continue, instead of stepping up for non-responders, because I have a scientific question about whether I should step up, then I randomize at week 4 to either step up or continue. And responders continue with the initial intervention. You see, I'm randomizing twice. I'm randomizing initially and at week 4. Why? Because I have scientific questions about how to initiate this intervention and how to address the needs of non-responders at week 4. I'm randomizing on a slow time scale. Randomizing on a slow time scale, it essentially means that you only have a few stages of randomizations in the trial, and the length of the time interval between stages of randomizations is relatively long. And the reason I'm randomizing on a slow time scale is because I have scientific questions about how to best construct an adaptive intervention in which the adaptation happens on a relatively slow time scale. So there's a strong connection between how fast you want to adapt and how fast you should randomize sequentially in the trial design that you're using to optimize that adaptive intervention. All right, but how do we use data from this trial to answer the 2 questions that I showed you before? I want to show you how easy it is and also how efficient these trials are for answering scientific questions about optimizing adaptive intervention. To do that, I want you to be in the following mindset. Suppose that I conducted the study and collected the data. Remember, I have an ultimate outcome, week 16 substance use. I'm collecting data about this outcome. And now I need to analyze the data. So the first question, my primary question that I want to answer, is about the difference between starting with coaching versus no coaching in terms of week 16 substance use. Because I want to know, should I initiate the intervention with or without coaching? To answer this question, all you need to do is take the mean outcome across the 3 cells, A through C, in which participants did not start with coaching, and compare it to the mean outcome across the 3 cells, D through F, in which participants started with coaching. Now, I'm assuming throughout that randomization probabilities are 0.5. And in that case, this is essentially equals to comparing half of my sample versus the other half, just like a 2-arm comparison, a 2-arm trial. Okay? Your entire sample will contribute information that will be used to estimate this effect. This is the main effect of the first stage component, coaching versus no coaching, averaging over subsequent components for responders and non-responders. All right, so how do we answer the second question? Remember, the second question focuses only on non-responders. So of course, I'm going to use data only from non-responders to answer this question. Should I step up or continue for non-responders? To answer this question, what I'll do is I'll take the mean outcome, week 16 substances, across cells B and E, in which my non-responders got the step-up option, and I'll compare it to the mean outcome across cells C and F, in which my non-responders got the continue option. So again, I will be comparing half of my sample of non-responders, because now we're only focusing on non-responders, to the other half of my sample of non-responders, just like a 2-arm trial. And this would be the main effect of the second stage tactic for non-responders, averaging over the initial components. Super simple. And we are not comparing individual experimental conditions, okay? We're collapsing outcome data across multiple experimental conditions in such a way that will help us answer multiple scientific questions about how to best construct this adaptive intervention efficiently. All right. There are many useful resources out there for you if you want to learn more about SMART. If you're beginning to learn about these experimental designs and, of course, about adaptive interventions, this is a paper that I recommend on the left. It's an introduction to adaptive interventions and to the SMART. The reason I like it is not because we wrote it, it's because it actually includes 4 examples, 4 templates of SMART studies that you can use that vary depending on the scientific questions that you're trying to answer. And I think it's very useful to me anyway. This manuscript on the right, this is by my amazing colleague, Denny Almerol. And the reason I highly recommend it is because I know many of you are in a phase where you're considering a SMART or an MRT or a hybrid as part of the preparation phase of most. In preparation or to obtain preliminary evidence to prepare for a full-scale trial. So this is where Danny explains how to use a SMART as a pilot study, what you should need to focus on, what kind of scientific questions, and also how to plan sample size for pilot SMARTs. It's super, super useful. All right, and now we are ready to talk about Jedis, because a Jedi is just a form of an adaptive intervention. And Jedi is an intervention delivery framework, just like standard adaptive interventions. And just like standard adaptive interventions, it includes adaptation. It guides how we should use dynamic information about the person to make intervention decisions. But Jedis are special because in Jedis, the adaptation happens on a much faster time scale compared to standard adaptive interventions. And by fast, I mean every few days, hours, minutes, seconds. So why do we need to adapt on a fast time scale? We need to adapt on a fast time scale because we're trying to address conditions that change relatively fast. And these conditions are not just changing fast, they're also likely changing people's daily lives outside of standard treatment settings. That's why Jedis typically guide the adaptation of digital components, because with digital components, we can deliver interventions in daily life and we can adapt interventions rapidly. To make this concrete, I want you to think about the digital intervention that youth receive in the emergency department from the previous example, okay? And suppose that as part of this digital intervention, every day we ask participants about their state and their context using EMAs. We use EMAs, we trigger them in the evening to ask them about their stress, their loneliness, their hopefulness. We also use GPS to monitor their location. And every day in the evening, if this combined information indicates that the person experiences high risk for next day substance use, we trigger a message with a protective behavioral strategy. Otherwise, we do nothing. So I want you to notice that there's an adaptation process here as well, because we're using dynamic information about the person's risk status to decide whether or not to trigger a message. So we're adapting the delivery of the messages, just like a standard adaptive intervention. But the difference is that here we are adapting on a much faster timescale. We adapt the intervention every day. Why? Because we're trying to address conditions that change on a daily basis. We're trying to address risk for next day substance use, which is expected to unfold on a daily basis. That's why we adapt the intervention on every given day. That's why we adapt on a fast timescale, because we're trying to address conditions that change fast. All right, nice and easy, but again, in many cases, we investigators, we have scientific questions about how to best construct Jedis. And again, I want to share with you 2 questions that I have about how to construct this Jedi. The first question is about the general effectiveness of a daily message with a protective behavioral strategy. You see, I'm not so sure that this message would be effective in reducing next day substance use compared to doing nothing on average in general. The second question that I have is about the conditions in which a message would be most beneficial. You see, here the assumption is that I should trigger a message when risk is high, but maybe I should trigger a message when risk is moderate to high. I'm not so sure. How do I answer these questions? This is why we have the micro-randomized trial, the MRT. Developed by Susan Murphy and colleagues, the MRT, just like the SMART, is a randomized trial that includes sequential randomizations. Remember, sequential randomizations, it means that the same person can get randomized multiple times in the course of the trial. But MRTs are special because they include rapid sequential randomizations on steroids, right? Sequential randomizations on a fast time scale. What does it mean in practice? It means that the same person can get randomized many, many times in the course of the trial, hundreds or thousands of trials, multiple times per day. And the length of the time interval between stages of randomizations is relatively short. Okay, for example, remember the questions that I have. I don't know if a message with a protective behavioral strategy on a daily basis in general is effective in reducing next day substance use and under what conditions. So what can I do? I can still collect every day data about the person's state and context with EMAs and with sensors. But instead of triggering a message when risk is high, because I don't know if I should, I have a scientific question. I randomize. Remember, randomizations are to help us answer scientific questions. So I randomize every day to message versus no message. And I collect data about my proximal outcome on the next day's EMA. The proximal outcome is next day substance use. So notice that now I'm randomizing a much faster timescale. I'm randomizing every day. Why? Because I have scientific questions about how to best construct a Jedi. And in a Jedi, the adaptation happens on a fast timescale. So again, I want you to see the connection between how fast I want to adapt in the intervention that I want to develop and how fast I need to randomize in the trial design that I set up to answer scientific questions about how to optimize this type of adaptive intervention. All right, but how do we use data from this MRT to answer the two questions that I showed you before? Again, I want to show you how easy it is and also how efficient these trial designs are for answering scientific questions about Jedis. So again, I want you to be in the following mindset. Suppose that I conducted this trial, this MRT, and I collected the data. Remember, my outcome is proximal, next day substance use collected following each micro-randomizations on the next day. Remember that the first question that I had is about the average effect, the general effect of sending a message with a protective behavioral strategy compared to nothing on next day substance use. To answer this question, all I need to do is take the mean outcome of next day substance use across all the days in which a message was sent across all participants in the trial and compare it to the mean outcome next day substance use across all the days in which a message was not sent across all my participants in the trial. Your entire sample and all the days in which you were micro-randomized will contribute information that will be used to estimate this effect. This is the average proximal effect of sending a message versus no message on next day substance use. And it's an average effect because you're averaging over all the participants in the study and all the days in which you were micro-randomized. And to estimate this effect, you will be taking advantage of both between person contrasts and within person contrasts in your proximal outcome. And that's exactly why these trial designs are so efficient compared to standard randomized controlled trial where you only take advantage of between person contrasts to estimate effects. Here, you take advantage of both. Another thing that I can do with the data, by the way, is I can look at time trend. I can see if this effect can vary with time because essentially I'm estimating an effect within each day across all participants. So I can see if it dissipates with time. Usually it does. Sometimes it's stable. I've never seen a case where the effect increases with time. That would be interesting to see, actually. Usually it dissipates with time because of burden and habituation. And I can also look at moderators of this effect to see under what conditions a message would be more beneficial than no message. Lots of really interesting questions that can help us inform a high quality optimal Jedi. All right, this manuscript on the left. This is an introduction to Jedis where you can learn about the components of Jedis and challenges and opportunities for designing Jedis and the motivation for Jedis. This manuscript on the right is my favorite introduction to micro-randomized trials by my academic sibling Tian-Shen Chen and Susan Murphy. It's really, there are, as I said, many other resources that you can use if you want to learn about these trials, but this is my favorite, I guess, because it also shows all kinds of biases that we can introduce when we're using standard data analytic methods to answer questions about optimizing a Jedi with a micro-randomized trial. And they explain it in a very nice and clear way. So those of you who are interested in how to analyze in practice. Because what I just showed you is the intuition for the data analysis. But if you're interested in how to analyze data in practice for micro-randomized trials, I highly, highly recommend this paper. All right. And I think that now we're ready to talk about METIs, because you know about adaptive interventions and you know about JEDIs. And you should know that in many cases, investigators want to combine the two. For example, what I want to do here is I want to take this adaptive intervention that I showed you before, where the delivery of coaching is adapted at week 4 based on early signs of non-response to minimal support. But at the same time, I want the digital intervention that youth receive in the emergency department and use throughout the intervention. I wanted to adapt the delivery of the messages based on daily signs of risk. So you see, I want to create an intervention in which human delivered components are adapted on a slow time scale, and the digital components are adapted on a fast time scale, meaning that I want to develop a multimodality adaptive intervention. And you can think about a multimodality adaptive intervention as an intervention delivery framework that integrates a standard adaptive intervention and a JEDI. Essentially, it's an intervention delivery framework that is supposed to guide the integration between human-delivered and digital components that are adapted on multiple timescales, slow and fast. All right, again, nice and easy, but investigators, we have tons of scientific questions about how to best construct METIs. And I only want to share with you one question that I'm personally very interested in, have been for the past 5 years or so. And this question has to do with the potential for synergy between starting this intervention with coaching and delivering the daily message. So why am I interested in the synergy between the human delivered component and the digital component? It's because I think that by starting with coaching as opposed to this minimal support, we can increase supportive accountability and therapeutic alliance, which will increase engagement with the message. So by starting with coaching, I can increase engagement with the message, and I can make the message more effective in reducing next day substance use on average. That's why I'm interested in the synergy. But how do I answer this question? You see, to answer this question, as well as other questions that I have about how to construct this METI, we need an experimental design that will allow us to randomize participants sequentially to human-delivered components and to digital components on multiple time scales, slow and fast simultaneously. And this is exactly what hybrid experimental designs do for us. For example, to answer the question about the synergy, what I can do is take the SMART that I showed you before, where we first randomized to the intervention with or without coaching. Then at week 4, we re-randomize non-responders to step up versus continue, and responders continue. And at the same time that I'm randomizing on a slow time scale to human delivered components, every day I collect data about the person's state and context with EMAs and sensors, and I micro-randomize to the message versus no message. So remember when I said these are not hybrid effectiveness implementation, these are hybrid optimization trials, because we're combining the SMART and the MRT, 2 optimization trials. And notice that now I'm randomizing on 2 time scales. On a slow time scale to human delivered components, and on a fast time scale to digital components. Why? Because we want to develop, we have scientific questions about how to construct a METI, a multimodality adaptive intervention, in which human delivered and digital components are integrated and they are adapted on multiple time scales, slow and fast. So again, I want you to see the connection between the time scale in which you adapt and the time scale in which you randomize. All right, but this looks very complex. I acknowledge that. Let me show you how to use data from this trial to answer the question that I posed before about the synergy between starting with coaching and the daily message. But to do that, I actually want to start by showing you how you can use the data to answer 2 other simpler questions, okay? So again, I want you to be in the following mindset. Suppose that I conducted this study and I collected the data, and there are 2 outcomes that I'm interested in. There's my distal outcome, week 16 substance use, And there is my proximal outcome that I measure following each micro-randomization, which is next day substance use. I'm interested in both. All right, suppose that I collected the data, cleaned it up, I'm ready to conduct my first analysis. And the first thing that I want to do with the data is figure out if my Maddie should start with coaching or with minimal support. Is it more beneficial to start my Maddie with coaching versus minimal support in terms of my distal outcome week 16 substance use? That's the first thing that I want to do with the data. How do I do it? Again, believe it or not, I will take the mean outcome across the 3 cells in which participants started without coaching, and I'll compare it to the 3 cells in which participants started with coaching, the mean outcome of week 16 substance use. Again, I will be comparing half of my sample versus the other half. Again, my entire sample will contribute information that I will use to estimate this effect. I will be using the same analysis that I used when I only had the SMART without the MRT. But because now I have the MRT in the background, the interpretation of the effect will be different. The interpretation of the effect will be different because now we're interested in optimizing a MADI. That's why we also have the MRT in the background, right? So now this would be the main effect of starting with coaching versus no coaching. Actually here, starting with coaching here versus no coaching on week 16 substance use, not only averaging over the second stage components among responders and non-responders, but also averaging over the delivery of the daily messages as part of the MRT, because we have the MRT in the background. We're testing this effect in the context of delivering these just-in-time interventions. That's why the interpretation of the effect is different, but the analysis is exactly the same simple analysis. All right. Suppose that the second thing that I want to do with the data is to figure out if, on average, it's beneficial to send a message with a protective behavioral strategy on a daily basis in terms of reducing next day substance use. Again, all you need to do is use the same analysis that I showed you before when you only had the MRT. You take the mean outcome of week 16 the mean outcome of next day substance use across all the days in which a message was sent across all participants, and you compare it to the mean proximal outcome, next day substance use, across all the days in which a message was not sent across all participants. Again, all your participants and all the days in which they were micro-randomized will contribute information that you will use to estimate this effect. Same way as before, when you only had data from the MRT. But now the interpretation of the effect is different because you have the SMART in the background. Now, this will be the average proximal effect of sending a message versus no message on next day substance use, where you're not just averaging over all the participants and all the days in which they were micro-randomized, you're also averaging over their randomizations to human-delivered components as part of the SMART because you have the SMART in the background. Because now you're asking and answering this question about the proximal effect of the message in a context where you're interested in optimizing a MADI, which also includes these human-delivered components. All right, so I think that now you know how to answer the question about the synergy, because remember, the question about the synergy was essentially a question about an interaction between starting with coaching versus not starting with coaching and delivering a daily message, where the focus is on the proximal outcome, next day substance use. I want to know if the effect of sending a message versus no message on next day substance use will be amplified, if it will be stronger, more positive for those who start with coaching versus those who do not. So what do? All I need to do is estimate the average proximal effect of sending a message versus no message on next day substance use, which you know now how to do. But I do this only among half of the sample who did not start with coaching. I do the same thing, estimate this effect among the other half who started with coaching, and I'm going to compare the two. That's it. It's a difference between differences. It's a difference between two simple effects. The effect of the message on next day substance use for those who did not start with coaching, and the effect for those who started with coaching. And this difference between differences, this two-way interaction, will tell me if starting with coaching amplifies the proximal benefits from sending a message on a daily basis. All right, data from hybrid experimental design can help you answer a wide variety of scientific questions about how to optimize multimodality adaptive interventions. This manuscript on the left contains tables with many, many questions that you can answer with a trial design that combines the SMART and the MRT. It also includes code that you can use to analyze the data and plan sample size with Monte Carlo simulations. We don't have yet closed form formulas for planning power, for planning sample size for hybrid designs, but we're working on it. Now, this manuscript provides an introduction to 3 different types of hybrid designs because guess what? The SMART MRT is only one combination that you can have. There are other types of hybrid designs that you can have depending on the scientific questions that you have. And this manuscript provides an introduction to 3 different trial designs that vary depending on the scientific questions that you have, and all are hybrid experimental design, hybrid optimization trials. All right, and with that, I'm happy to open it up for questions, but I also wanted to mention before we do so that our website includes tons of resources that you can use to plan sample size for different kinds of optimization trials, to analyze data from smarts, MRTs, hybrid designs, different kinds of smarts and MRTs, and so on. And we also have learning resources. We have online modules that you can use and recorded presentations and seminars that you can listen to. Another thing that I find really useful, and I also get feedback from investigators that they find really useful, is web pages on our website that contains examples of smarts and MRTs that are currently used, like studies that are either in the field or completed. So you can see how other researchers in different fields deployed these experimental designs to answer different kinds of scientific questions. I think it could be really useful.